Tokyo Guidelines 2018, Acute Cholangitis Management. Welcome to today's episode, where we will be diving into the Tokyo Guidelines of 2018 for the management of acute cholangitis, a topic of critical importance for anyone involved in emergency medicine, gastroenterology, or surgery. Let us begin by framing what acute cholangitis truly is. This condition is a life-threatening bacterial infection of the biliary tract, almost always stemming from some form of biliary obstruction. Common causes include stones, strictures, or even tumors blocking the normal flow. The 2018 Tokyo Guidelines offer a standardized approach for diagnosis, grading the severity, and determining the appropriate treatment. More than ever, these guidelines emphasize the necessity for a rapid response and timely biliary drainage. Now, as we journey through this topic, remember that the foundation of management is the accurate assessment of severity, which will guide the urgency and specific interventions required. First, let us discuss the diagnostic criteria set forth by the Tokyo Guidelines. A proper diagnosis relies on a combination of clinical signs, laboratory findings, and imaging results. According to these guidelines, you should look for evidence of systemic inflammation such as fever or shaking chills, or laboratory markers of an inflammatory response. Think of elevated white blood cell counts or a raised C-reactive protein. Next, investigate for signs of cholestasis. This could be jaundice on physical examination, or elevated enzymes like alkaline phosphatase, gamma-glutamyl transpeptidase, or bilirubin on laboratory analysis. Finally, imaging studies are crucial. On ultrasound or other scans, look for biliary dilation or a clear cause of obstruction, such as a stone or a stricture. A definitive diagnosis is made when all three elements, systemic inflammation, cholestasis, and imaging evidence, are present. However, if you have evidence of both systemic inflammation and cholestasis, and no alternative explanation is found, the guidelines allow that this may be sufficient for diagnosis as well. The next major cornerstone is grading the severity of acute cholangitis. Let's break this down into three categories. Grade 3, or severe cholangitis, is characterized by any signs of organ dysfunction. This could manifest as low blood pressure requiring medication, difficulty breathing, confusion or altered mental status, issues with blood clotting, or reduced urine output. Organ dysfunction is always a serious red flag. Grade 2, or moderate cholangitis, is identified by the presence of any two features. These include a white blood cell count that is too high or too low, a fever of 39 degrees Celsius or higher, being 75 years of age or older, a total bilirubin level above 5 mg per deciliter, or low albumin in the blood. Grade 1, or mild cholangitis, is diagnosed when neither the moderate nor severe criteria are met and the patient responds well to initial medical therapy. Let us now transition to the management recommendations, which are based on the severity grade. Treatment always involves two primary strategies: medical management and biliary drainage. For everyone, regardless of severity, start with intravenous fluids and correct any electrolyte imbalances or bleeding issues. Administer broad-spectrum intravenous antibiotics immediately, targeting the most common bacteria, which are typically gram-negative and anaerobic organisms. Definitive management centers around biliary drainage. For patients with moderate or severe cholangitis, urgent drainage is imperative. The preferred method is endoscopic retrograde cholangiopancreatography, which serves both diagnostic and therapeutic purposes. Through this procedure, clinicians can visualize the bile ducts and perform interventions like removing stones or placing stents. If endoscopic retrograde cholangiopancreatography is not possible, the guidelines suggest alternatives such as percutaneous transhepatic biliary drainage or, in centers with appropriate expertise, endoscopic ultrasound-guided drainage, which is an emerging technique. The timing here is essential. Drainage should take place as soon as possible, ideally within 12 to 24 hours for severe cases. For those with mild disease, start with antibiotics and supportive care. If the patient improves quickly, biliary drainage can be planned electively during that same hospital stay. However, if there is no improvement within 24 hours, the patient should be reassessed and managed as a moderate case, meaning urgent drainage becomes necessary. What is especially noteworthy in the 2018 update, the guidelines stress that antibiotics alone are not enough. Definitive drainage is the only way to resolve the underlying obstruction and sepsis. They provide clear guidance on starting broad-spectrum antibiotics early and de-escalating therapy based on clinical response and culture results. Timing is everything. Delays in drainage for moderate and severe cases consistently lead to worse outcomes. Finally, the Tokyo guidelines highlight the importance of a multidisciplinary approach. Successful management of acute cholangitis depends on seamless communication and coordination among emergency physicians, intensive care specialists, gastroenterologists, interventional radiologists, and surgeons. That brings us to the end of our deep dive into the Tokyo guidelines for acute cholangitis. For clinicians, learners, and healthcare teams, these principles are essential to ensure rapid, effective, and life-saving care for patients suffering from this dangerous condition. Thank you for joining us on this journey, and stay tuned for more evidence-based discussions in our upcoming episodes. If you enjoy the content, please like, share, and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.